Okay, so good morning to all of you. And I must thank the organizers for inviting me to do this talk on behalf of, I think, Cancer Control Program. So what I'm trying to touch you with today is during the next 1.5 hours is to take you through with some of the aspects in palliating the neurological patients. You would have already listened to many lectures with general palliative care and palliative principles and palliative care with other disorders, other system disorders. So today we are trying to discuss neurological aspects of palliative care. So as a beginning, as introduction, we all know palliative care is actually for patients who have got death sentence. Now, when you are stricken with a disease, few things can happen. One is cure. Doctors, everyone get together and restore the clinical problem back to normalcy. Second is maybe it's possible to modify the disease process, though we cannot cure it. There may be disease modifying treatment. There's something that you can do. And the third group where you diagnose a progressive illness which is going to reduce your lifespan, and then there's no cure also. So such patients, we consider them as received death sentence by the nature. Unfortunately, doctors will have to break this news for certain patients. Now, this question would have been discussed before also. We know palliative care is a life-limiting problems, and there are a lot of issues, not only to the patient, but also to the family, with physical issues, psychological problems, and social issues, spiritual issues, immense amount of issues. Other patients also have issues when they are not having palliative problems, but here is a patient who is dying with a lot of issues. And general restorative care sometimes do not address some of these issues unless you have been trained to look at the patient from palliative aspect. So anyone who knows palliative care will have to switch your gears in a different direction when you diagnose a patient with palliation. You cannot go for certain investigations, certain treatment options with certain palliative care patients. So the moment you diagnose a patient is palliative, certain options are not available and certain other options will become available for them. What kind of disorders need it? We have already listened that cancer, some of the cancers are curable, but there are others which can progress. In fact, palliative care was started with cancer patients, but then later on, people found that same amount of physical, psychological, spiritual issues had been there for progressive organ failures also where there is no cancer. So there's non-cancer disorders also needing now palliative care. And who delivers palliative care? In developed countries, there are palliative consultants who are qualified specialists with a team of doctors, and maybe there are wards. So there's palliative teams like in other teams available in hospitals. And also they have a link with community-based teams also, because with regard to palliation, it's mostly in the community plus hospital bed, both. As opposed to, say, for example, any other specialty like cardiology or neurology, you need more ward-based treatment. But here the patients are palliative, they prefer to be treated from home. Please don't take me to the hospital. I would like to stay at my home and do everything at home. So community-based teams are there, and they are in liaison with the hospital-based teams in developed settings. We currently do not have a community-based teams. We are trying to establish it in the initial process. I think started now. So we are going to have hospital and community-based teams interacting with each other, so that patients are benefited from this combination. And also, palliative care covers many aspects, as I mentioned before: physical, psychological, and social and spiritual aspects. Palliative care should be delivered by a team, not by one person. So when there's a team, The team members can look into many aspects. So there'll be a lot of people in the team delivering palliative care. It's a interdisciplinary team, not a multidisciplinary team. We'll discuss the difference between the two. Strongly mentioned multidisciplinary, but it's an interdisciplinary. We have multidisciplinary meetings in hospital right now at the moment. So cancer patients are discussed with the specialists from various teams sitting together and discussing various aspects. But when it comes to interdisciplinary team, the difference is multidisciplinary teams, people look from their own aspects with goals separated to their own areas. Say, for example, I am a neurology specialist participating in a multidisciplinary team meeting. I have my own goals with regard to the neurological problem with the patient. But whereas in interdisciplinary team, all the members looking at one goal and see how can each member contribute to reach that particular goal. So in palliative care provision, usually you set goals sitting with the patient and the family, and then the whole team is trying to reach that goal which is defined beforehand. So the team members would be a physician, maybe whatever the specialty is, and maybe they're a palliative care physician. Currently, we don't have any right at the moment. Specialists, qualified specialists in palliative care. Palliative care nurse, physiotherapist, and occupational therapist, speech and language therapist, social worker. So the whole team who can do something to this patient. Is there anything that someone can do something to this patient, they can take part in this team. So as long as you can relieve this patient from suffering. So neurological aspects, neurological aspects of, there can be two approaches. Palliative care and neurology comes together in two situations. Number one is neurological aspects of advanced cancer. Already a cancer patient coming with neurological aspects, maybe cord compression, or maybe secondaries in the brain, or maybe paraneoplastic manifestation. And the second way is where the patient's problem is palliative neurological problem. So it's an advanced neurological problem needing palliative care, like life-limiting progressive neurological disorders. So his palliative care provision is different in neurology patients as opposed to other patients with palliative care. Well, neurological palliative problems, I'm talking about progressive neurological illnesses where you have a short lifespan and you are destined to die with the neurological problem. Usually, neuropalliative conditions, they have a longer duration compared to other non-palliative problems. For example, dementia patients may live with the problem for maybe 8 to 10 years. The motor neuron disease patient might live for about 3 to 5 years. And neuropalliative patients have their specific problems, not much seen with other conditions. Like speech issues, dysarthria, or maybe swallowing problems, or cognitive dysfunction. Their mobility may be affected because of the neurological problem. So because of this, even though at the onset of the neurological problem, the patient is fully functioning, but it's likely that if you give an adequate period of time, they may develop cognitive dysfunction, they may develop language problems. So the very important thing when you are looking after a palliative patient is for you to be able to talk to the patient, find out what the problems are, and let the patient tell us how they want to be managed. So that may not be possible when the disease advances, their decision making will be affected, their communication will be affected. They may have difficulties in communicating whatever they would like to the doctor. So it's likely that they can have problems, or the doctors will have problems in communicating or getting the consent or agreement with the patient as to what they're going to do as the disease progresses. So because of that, it's a good decision to sit with the patient at the beginning of the illness and talk to the patient and tell them, maybe you will lose your cognition, your communication in the future, so you will not be able to tell us how you want us to manage you. Why not we sit together now and let us know how you would like you to be managed in case, for example, you develop breathing problems where we think of intubation, in case where we think of nutritional problems, swallowing issues where you might need a PEG tube, or many other major decisions. Shall we sit now and discuss? Because as the time goes on, you may not be able to tell us how things, how you would want us to manage you. So advanced care planning is done before patient loses competency and cognitive dysfunction and language problems. That may be necessary in neuropalliative patients. It's good if you can do it, so that when a time comes where a patient have lost competency or cognitive dysfunction or language deficit, patient has expressed how he want to be managed in the past. You can even keep it as a written document, or even the fact that they have expressed how they want to be managed is enough. If the family is known how they would like to, whether they will be happy for intubation in case respiratory failure comes, and so on. If the patient has expressed their wishes, that's okay for us. So neuropalliative care patient needs a little bit of a care provider, needs special training in handling cognitive behavioral problems, communication problems, spasticity, mobility, and postural handling. So caring for palliative care provider for neuropalliative patient is a little bit of extra training with regard to these aspects. If you look at neurological problems, they are broadly divided into two: short-term neurological conditions and long-term neurological conditions. Short-term ones, example, Guillain-Barré syndrome or Bell's palsy, all of you know. And long-term ones, again divided broadly into two, progressive and non-progressive. Now, non-progressive ones are like stroke, polio, cerebral palsy. They hit the patient with acute problem, and then patient lives with the disability or the neurological deficit for the rest of the life. Whereas progressive neurological problems are progressing on the time scale, and patient accumulate neurological deficit with the time. Examples: motor neuron disease, all of you are aware, Parkinson's disease, multisystem atrophy, dementia. So these progressive long-term neurologic conditions are the ones which needs palliation, neuropalliative care. If you look at the trajectory, a trajectory is how the patient progress on the time scale. Now here we take the neurological deficit or the disability, how it progresses on the time scale. You can look at several trajectories. On the top, you see a trajectory where the neurological deficit or deficit is accumulating, and then you have to live with the deficit rest of the life. In the childhood, cerebral palsy or polio, whereas patient lives with that deficit, there's no progression. And the second trajectory is where in the late life, you have a deficit and you live with it, a slight improvement like stroke, but then you have to live with that deficit. The third trajectory in neurological progressive conditions is relapsing, remitting, but there's progression, there's accumulative baseline deficit also. A good example is multiple sclerosis. If you have heard of this condition, which is commoner in West Caucasians, but we see quite a number in Sri Lanka at the moment. Numbers are less, but we see them. Numbers are more in Western countries, so among Caucasians. And the other trajectory is gradually progressing at a rate. Example, motor neuron disease, Parkinson's disease, all these degenerative conditions, they progress at a particular rate with accumulative deficit. So prolong, the last trajectory is where the ones we need palliation. Now, there are other neurological groups. So, for example, vegetative state, persistent vegetative states. You would have seen this kind of patients where after head injury, you are totally unconscious, and then you take about several months, and then gradually they become conscious. They come out of the intubation, the ventilator, but they have sleep-wake patterns. They sleep during the night and wake up during the morning, but they are not aware about what is happening in the surrounding. They don't respond to environmental stimuli. You cannot talk to them. You cannot communicate with them. They're just living, but there's no adequate brain function. Sometimes they live for a number of years. If the family care is good, the supportive families, they live for a number of years. They also should coming under palliation. They need palliative care. And excuse me, minimally conscious state is little less of a persistent vegetative state. They are like vegetative, but responds to the environment a little. So they are not fully conscious, but there's another state where I need palliative care. We have seen this many times before by previous speakers, the old model and the new model for palliation. If you look at the neurological, you can see the trajectory, the patient's deterioration of the time scale. And I have drawn another line in red, if you can see it, where the burden of symptoms and the issues and problems with the patient and the family gradually gets worse and worse. A different trajectory. There are dips in the first group, like the first graph is actually a condition like multiple sclerosis, where you have dips in the trajectory. During the dip, the problems increases and then comes back to normalcy. On the right-hand side, you see a patient with dementia, gradual progression over the years with the declining function. And on the red, I have put the problems and issues for the patient and the family gradually increases on the time scale. Few months before, there are triggers indicating a lot of problems. These are the symptoms that the patient, problems that the patient had few months before. Pain is a significant problem, and cognitive problems, weight loss, infections, aspiration, swallowing difficulties. So issues are accumulating closer to the terminal stage. Any neurological patient needs restorative care, that's a neurology circle. And then rehabilitation is trying to get the lost function back again by therapy. A second group of things that we do. And then palliative care is where you try to palliate for symptoms. So these three circles are there with all neurological patients, which is also there for neuropalliative patients also. Neuropalliative patients, we do not completely give up. The restorative aspects are still seen. The neurologist will be looking at the restorative aspects of the problem. At the same time, a bigger input is coming from the palliative team for the symptom control. And the rehabilitation team also is looking at the try and modify the function of the patient. I will not go through this. So what are the kind of diseases which need palliative care? We have discussed about motor neuron disease and multiple sclerosis, advanced Parkinson's disease, progressive supranuclear palsy, multisystem atrophy, Huntington's disease, dementia, and incurable cerebral tumors, strokes. Some of the strokes can be palliative. Most strokes are not, but a small percentage can become palliative. They have poor prognosis and they die within a few weeks and few months. They need palliative care. Motor neuron disease, let's discuss a little about one disease out of this. Motor neuron disease, we see quite a number as neurologists, but not with the general practitioner, or the physicians may not see many. They are progressive, it's degenerative. This happens due to deposition of a protein in the motor neurons, in the first order, second order motor neurons, the commonest protein that is deposited is called TDP43, TAR DNA protein. And this leads to destruction of motor neurons. Now, it can strike at various levels in the nervous system. Sometimes they present with bulbar symptoms, where the bulbar nerves. The bulb means medulla oblongata, and that supplies your speech and swallowing muscles, the vagus, the 9th and 10th nerve. So whenever you see a patient with swallowing and speech problems, we tend to say patient's got bulbar palsy. If it's purely speech and swallowing issues. So one of the differential diagnoses for swallowing and speech issues as a presentation is motor neuron disease, where it strikes the nerves involving that region, bulbar onset. And then there are limb onset ones, where initial problem is actually either upper limb or the lower limb. I'm expecting Ayesha to keep track with the time and let me know if I am going over the time allocated. The third group is respiratory onset, which is very rare. It's very rare to have respiratory onset motor neuron disease. Having said that, in this whole disease, it affects all the skeletal muscles in the body, your limb muscles, your upper limbs, your lower limbs, your swallowing muscles, your respiratory muscles. But the affection of the respiratory muscles decide how long you're going to live. It's not the other muscles. Say lower limb muscles, when they get affected, you will find it difficult to walk. You might become bedbound. But when the upper limbs are affected, Jayakumar, I'm in the lecture. I will call you back again. I will call. You are in the hospital. No, I'm doing a lecture at the moment. Delivering a lecture. Can I call you back again? Okay. Sorry. So when respiratory muscles are affected, that decides how long you're going to live. All the other muscles, if they are affected, not a problem. You can still live. But respiratory muscles, your swallowing issues, that becomes a problem. You need tube feeding, you need supporting from the ventilation. So in fact, respiratory muscle involvement decides how long you're going to live. That's the reason why when you see a patient with motor neuron disease, you need to do a respiratory function on those patients. You are aware that respiratory volumes has a reserve capacity. All of you have a reserve volume, and you and I breathe normally in the tidal volume area. So when you're in the tidal volume, if you are a person who is seated all the day and not doing much work, you can manage within the tidal volume. You will not need the reserve volume. If you start running around here and there, maybe staircases and so on, you may need the reserve volume. What I'm trying to say is you can lose your reserve without your knowledge. In motor neuron disease, your respiratory reserve can shrink without your knowledge. All of a sudden, when you try to climb stairs, or maybe an infection, suddenly you get an infection, the tidal volume is not adequate to fight. So you need ventilation all of a sudden. So the message is you can lose your reserve respiratory volume with progressive neurological conditions. Unless you have tested your respiratory volumes, you're not going to know that. All of a sudden, you get an infection, and then you go into respiratory failure. This is a common occurrence with motor neuron disease. They gradually lose their respiratory reserve, and at a particular stage, because of problems with clearing the bronchial tree, they develop an infection. They find it difficult to maintain the saturation, and then they are brought to the hospital. You find that the patient in respiratory failure, the accepted norm, anyone presenting in the emergency with respiratory failure is, if it's type 2 respiratory failure, you will ventilate. You put the tube in. And what happens? You put the tube in, you connect to the ventilator, and this pathology is not a reversible problem. So ventilators were initially developed to bridge until your respiratory problems reverses. You can keep them on ventilator. That was the purpose of developing ventilators. Ventilators were not developed to keep patient life going on for ages when the respiratory function is lost by a neurological condition. So the moment the patient is fixed to the ventilator, you find that you will not be able to wean them off the ventilator. So it's important that you check the respiratory function, any patient with motor neuron disease, and document it. The forced vital capacity, every 3 months, we document on the follow-up books. So by the time the patient presents to the emergency with respiratory failure, they look at the book and they see the pre-morbid vital capacity, before the infection, what was the respiratory function. And it gives indication that this was motor neuron disease. And if the vital capacity pre-morbid level is less than 1 liter, emergency team is not supposed to ventilate. If it's more than 1 liter, it's a beginning of the motor neuron disease, they may come back after ventilation. So we can ventilate and treat. So it's not a blanket decision that motor neuron disease cannot be ventilated. In the early phase, where respiratory functions are good, there's no problem. As long as you have the respiratory function when the patient has not developed the infection. Pre-morbid respiratory function, forced vital capacity is available, then you know there is an infection causing respiratory. The component by infection is much more the reason for the respiratory failure. So there's chance that they can come back. Now, I'm not going to go into the details of that. He's a guy in America who developed this particular disease, motor neuron disease, which is called by the name amyotrophic lateral sclerosis, USA. Asia, we call it motor neuron disease. Even in England, they call it motor neuron disease. In USA, he was a popular football player. So he was a player, people were waiting to see him on the field when there's a match. But after a while, his performance came less and less. And then one day he fell on the ground and he was not appearing in the team for a while. And then he comes out of the place and say, I've got motor neuron disease. I've got amyotrophic lateral sclerosis. The whole USA knows this disease by his name, Lou Gehrig's disease. So amyotrophic lateral sclerosis is a term that is used in other countries. Motor neuron disease is what we use, used interchangeably. And well, a little bit about the Liruzol. Is there a drug to cure this disease? We don't have a drug to cure, but we know there's a drug which has shown evidence that it can prolong the life by a few months, but very costly in UK. And there are physicians who use Riluzole. There are others who do not use, because the goal of treating motor neuron disease is not life prolongation, but is actually to improve the quality of life plus the life duration, both of them. This particular trial has looked at the quantity of life only. In fact, extending suffering life, patient people question whether it is okay. So, and anyway, it's going to be a few months extension by treating them with number of years with this drug from the diagnosis. It can cause liver problems. The drug is available. People can bring it from India. It was available, but not in the public system in Sri Lanka. And there's another newer drug which is licensed to be used. Is an injectable stuff. You have to give injection every 2 weeks and so on. But then palliative patients giving injections to what the goal is a question again. That's very costly, extremely costly. It's not available for us in Sri Lanka at all. But then we need to look at what our goals are in treating this condition. People are doing research on the cure aspect of it, but we don't have a cure right at the moment. You all have heard of this particular person, Professor Stephen Hawking, who developed this disease, but he lived longer period than expected. And when I met a neurologist in USA, he said probably the diagnosis was wrong, but he was living for a number of years. Probably the diagnosis could have been something else. So palliative approach to this kind of patient, let's discuss the palliative approach. Aim is to improve the quality of life. And there will be effects from the disease. There will be direct effects and indirect effects. Direct effects are neurological or psychological, and indirect effects again are sleep problems and pain and so on. So there'll be physical problems like dysarthria, dysphagia, drooling, and psychological problems. Patient is fully alert with this condition. They do not develop cognitive dysfunction until the late part of the disease. The protein that is getting deposited in motor neuron disease, the TDP43, is it the same protein that gets deposited in the condition called frontotemporal dementia? So same root pathology causing two different problems. We don't know how the same pathology has two different phenotypes, but we know that people with motor neuron disease, as the time advances, a percentage, a small fraction, will develop the features of frontotemporal dementia. And on the other hand, people who are presenting with frontotemporal dementia, with the time, some of them develop motor neuron disease also. There is a link, but we don't understand why this happens. So we know that motor neuron disease, you have physical deficit, physical disability, but cognitively they are intact. Their memory, their language, everything intact until the last moment. Language can get affected due to dysarthria, due to tongue atrophy and so on, but their cognitive functions are intact. It can get affected if you have frontotemporal dementia in a small percentage of fellows. So they will have social problems, understandable, and spiritual problems. Why me? Why not the other person? Why this disease strike me? My friend, my neighbor, my next fellow who didn't live like I did. I was very honest and I was going to the temple, doing everything, but why me? So always this question to be answered. They are suffering inside within their mind. So advanced care planning we discussed, because motor neuron disease likely to progress in the future to the stage that you may not be able to use your language, cognition, and so on. So why not we sit now and discuss about maybe ventilation, maybe tube feeding, or future disability, how you want us to manage you. So we think of this and we sit with the patient and discuss. Initially, after diagnosis, we break the bad news. Doctors are very well trained to break, now it's called breaking serious news. You know how to break serious news without causing distress or anxiety within the patient. A good doctor can sense at what degree of information patient is like to go over the threshold, cannot tolerate, so you stop there. So it's a byway thing. You feel how the patient responds and then you give information. So immediately after breaking this news of that you have got motor neuron disease, now you are going to sit with the patient and discuss advanced care planning. You are going to talk about you will need ventilation, you will need tube, a lot of bad news now. Patient get further distress. So you might cause problems. Our attempt in caring for palliative patient is to keep them psychologically, relieve their suffering, not to cause distress by giving more information. So we have a problem when you try to discuss advanced care planning with the patient. You have to find a suitable timing and how much patient will understand and tolerate. So may not be possible in the initial phase. And sometimes certain patients, you may not do it to the advanced stage because patient is not tolerant for information. If the patient comes and asks you, doctor, tell me everything, what can happen to me? I would like to listen to it. I'm tolerant. Of course, go ahead. No problem. You can discuss everything. But if the patient says, sometimes the family approach you and say, my father is not tolerant for information. Doctor, please don't tell anything to him. Tell everything to us. We'll keep it a secret. Don't tell the patient. We'll manage without telling him. There are certain families I know, cancer patients, where you do not divulge the information and family and the doctor get together and manage their patients. Whether it is correct, we have to ask ourselves. When people ask me, the family members, I say, now the patient has a right to know. And if you do not tell them, maybe we are causing harm to the patient. Maybe he would like to tell us what he want to do before he die. Maybe he has certain plans, unfinished businesses before he expire. So we know how to break the bad news. So you can be by the side. We can do it to the level that patient can tolerate and keep them informed little by little, piece by piece. We'll keep them informing. Sometimes family agrees. Most of the cases, family agrees after discussing this. So it's important that you do the advanced care planning, especially with neurological disorders, and then let the patient express their wishes as to with regard to future management in case you need ventilation. Now there are ventilator machines which you can, home ventilator machines, where you can keep them going for maybe a few months or a few years. Sometimes there are patients who opt for this, but in Sri Lanka we cannot use public ventilators for this purpose because the ethical principle of justice comes into the middle. We have to be just fair by all patients. But when the patient says, I have got the ventilator, I have got enough machines, money, I can buy anesthetists, I can have a maybe ICU at home, so no problem, you can go ahead, provided you give the information as to what are the pros and cons of long-term ventilation. And also, before starting ventilation, patient must declare, he should say when to disconnect. The patient must tell us when they want us to disconnect. In Sri Lanka, very rare, motor neuron disease is being ventilated at home. Few cases are there, but not very common. So when to do the advanced care planning, it's best done soon after the diagnosis. Or maybe when the condition deteriorates, patient may be tolerant for information. He may ask you, what's going to happen to me? So you have to find a suitable timing to discuss advanced care planning. Advanced statements also there. In Sri Lanka, they are not legally binding though. So, but as long as written documents are there, doctors can look at them and take them as patient's choices when you're deciding. Advanced directives, advanced decisions to refuse treatment, lasting power of attorney, which is happening in other countries. Sometimes they bring, sometimes certain patients with these documents come to Sri Lanka, but law of Sri Lanka applies on them, so we are not legally binding for those. But you always, because autonomy, the most important ethical principle, you have to give information to the patient and agree with whatever you're doing. Patient's wishes are important. Patient's previous wishes or current wishes are important. So symptoms has to be controlled. This is the main thing that we need to do. Dysphagia is very common. Dyspnea, weight loss, speech problems, pain, constipation. There are some of the symptoms that motor neuron disease patients develop. And dyspnea is because your respiratory muscles are involved. In the initial phase, when the respiratory muscles are involved, they will not complain, I'm breathless, I'm short of breath. They will not say that. Instead, they will say, I'm orthopnic, I can't lie and sleep. I'm tired and I get nightmares and recurrent infections, daytime sleepy, confusion. When you look at the respiratory function as far as neurology is concerned, we have two groups. One is expiratory muscles, which is necessary for clearing the bronchial secretions, and inspiratory muscles, which is necessary for maintaining the oxygenation. So sometimes predominantly one of these groups can get affected. Usually it's combined both at the same phase. So if your patient cannot make a good cough, you don't need to check respiratory function. Now we were discussing about testing for respiratory function in motor neuron disease, which is actually you're blowing into a pipe. All of you would have seen the spirometers, the respiratory function, how they affect. But these patients who are already having problems, who are ill, sometimes we have to make sure that they are not bothered. They should not be bothered by many things. So the moment you ask them to blow through the pipe, sometimes it's disturbing for them. So people have decided various gadgets to keep it just next to the nose and find out what is the expiratory pressure and the inspiratory pressures and so on. Without disturbing them, you can get an idea. Even in Sri Lanka, even without anything, you open the shirt, expose the chest, ask the patient to take a deep breath and expirate and inspirate deeply. You will get an idea. Our doctors are very experienced, so they look at the chest expansion. You can get an idea of how much chest expansion is. You can even get a single breath count. You can ask the patient to cough. If the patient cannot make a very explosive good cough, maybe they cannot clear the secretions. So now, if the respiratory muscles are clinically obviously affected, we don't need to assess respiratory muscle function or vital capacity or whatever. It's not necessary. You conclude this patient in the terminal stage. The moment respiratory functions are affected, you know this patient is going to live only for 6 months. Yesterday, I had a patient seen by many doctors, came to me too, with diagnosed case of motor neuron disease. He's still walking, he's drinking and eating. When I checked the respiratory function, opened the shirt, asked him to take a deep breath, he could not make it. Very subtle expansion, and he cannot cough. This disease has gone for 3 years by the time I saw him yesterday. And then I explained to the family that this patient's prognosis is just 6 months. Though he is living normal at this moment, his life going to be only 6 months. So nocturnal hypoxia is the first indication of respiratory failure. When you are lying down, you will have a lot of symptoms of nocturnal hypoxia. You have frequent wake-ups at night. And that's the time you need to fix the NIV, non-invasive ventilation, which is indicated in these patients. This is the maximum we can do for them. Not the invasive ventilation, but non-invasive ventilation. All of you are aware, you have a mask and then you fix to a machine, you give pressure support, and that keeps them going a little longer. In fact, there is evidence that if you fix them with NIV in the early phase, they can go a little longer. There's evidence for life prolongation also, and they have comfort also. Having said that, we know pathology progresses. There will be a time that NIV is not going to be effective. So what happens during the NIV? Gradually, they will go into type 2 respiratory failure, and carbon dioxide causes drowsiness, and they die in sleep. That's a usual mechanism of death. So ideally, we should be checking we can check at home. If you buy a pulse oximeter, at night you can fix it to the finger and then check whether your oxygen saturation goes down during the night. That indicates you're in respiratory failure. That is the first thing to happen with respiration. Only thing, either you have to have an alarm in the pulse oximeter indicating, recording, whatever the values. If you follow with forced vital capacity, again, you can find out. And there is sniff nasal inspiratory pressure gadgets, which are not available in Sri Lanka. These are the ways in finding out what's happening during the night. Supposed to do every 3 months. Out of them, if the patient can blow to the pipe, you may go with the forced vital capacity. Or if the patient is advanced, maybe you can check the saturation. So if you think patient is hypoventilating during the night, that's an indication for NIV, non-invasive ventilation. I get the support of an anesthetist to fix this, and they need to buy this machine because this is not provided from the hospital. It costs currently about 300,000, I suppose. Maybe you have to give a trial before asking them to pay for it with the machine and see whether it's comfortable, and then you go for it during the nights. So it's not that we are not doing anything for these patients with motor neuron disease. There are so many things that we can do for motor neuron disease patients. And when the disease advances, their breathing is best in this particular position when the muscles are failing. So invasive ventilation, we have discussed before also in those patients who have wishes and they can afford, after extensive discussion and evaluation, sometimes you recommend this. This is a case that happens overseas where patient requested euthanasia, which is not there in our country. And so court has given the ruling, and then so this patient got euthanasia, which is not something that we are going to discuss today. Maybe euthanasia will be discussed in a different talk. With regard to NIV, that will relieve you from suffering, it improve the quality of life, and can be used intermittently in the initial phase and then will be persistent, and then at the last stage, of course, this is not going to be adequate. And it's portable and does not affect the speech, improve sleep at night. That's the one new gadget from overseas. Our ones are having the full face cover. With regard to dysphagia, as I mentioned before, motor neuron disease affects many groups of muscles. It can affect the bulbar group, it can affect the respiratory group, it can affect the limb muscles. Now, they can be affected in various proportions. Sometimes you get more bulbar involvement than anything else. So their main problem is speech. Their tongue becomes wasted. Their swallowing gets affected early. When the swallowing gets affected early, your nutrition is going to get affected. And also you run a risk of aspiration. The moment you drink, it goes to the lungs. And then, excuse me, then you have problems. How can you minimize this is now you have to give the drugs, you have to maintain the nutrition. Your oral pathway is getting affected because of your the pharyngeal phase of deglutition, the swallowing reflex is not working. So you are compelled to choose tube feeding for this patient. There are two kinds of tube feeding available for us. One is NG, nasogastric. The other one is PEG. So now why we go for tube feeding is because you have to maintain the nutrition. You have to give the water, you have to give the nutrition. That is the reason why you are putting a tube. But both kinds of tubes will deliver liquid feeds only. You cannot give solid feeds through tubes. Our stomach is not ready for tube feeding alone. When you give tube feeding with liquids, excuse me, with liquids, they tend to regurgitate. So in other words, when you put an NG tube or when you have a PEG tube, they have higher chance of aspiration pneumonia. They can regurgitate and cause aspiration. So it doesn't prevent aspiration pneumonia. People have the wrong impression that tube feeding is to prevent aspiration pneumonia. Yes, at the deglutition phase, when you orally feed, where there's a chance of aspiration is prevented by having a tube, but it increases aspiration because there's liquid in the stomach which can regurgitate and aspirate into the lungs. So net problem is actually there will be more risk of aspiration when you have a tube. So now to prevent aspiration, there are a few steps that we recommend for patients on tubes. One is give in small amounts. I ask them to take 150 at a time and increase the frequency, and keep the last feed well in advance of sleep before you become horizontal. And also, whenever you are feeding through the NG or the PEG tube, you must keep the patient seated position. Never do it in the lying down position. And also maintain good oral health with good brushing and all that, because the organisms in the mouth are the ones who is going to get into the lungs. So these are some of the aspects, anyone who is on tubes, that you need to take precautions to prevent aspiration. It is very common in stroke patients. Strokes very common. They are having NG tubes, and aspiration kills them. Aspiration reduces their improvement of the neurological problem. And there are people who are with early swallowing issues. There are techniques of swallowing which can prevent aspiration. So speech and language therapists sometimes teach these patients with regard to various techniques when you are orally taking meals, how you can prevent aspiration. One is actually, all of you are aware that in our respiratory phases, the inspiration and the expiration, at the end of the expiration, next thing you're going to do is inspiration. So if you are swallowing at the end of the expiration, that is not good. But immediately after swallowing, you're going to inspirate. So one of the techniques they employ is you swallow in the end of inspiration phase. You take a deep breath in and then swallow. Next thing you're going to do is to expirate. Very easy to get the things out of the place. So there are other techniques also which speech therapists train them with regard to improving reducing the aspiration when they are on oral feeds in the early stage of dysphagia. And sometimes patients' swallowing problem with motor neuron diseases, swallowing problem advances at a rate. And there is now, it is advanced to the stage that you need to go for a tube. Now, everyone who is having dysphagia to the degree that needs tube feeding, should they always have a tube is a question. Can my patient go for an NG tube or a PEG tube? So the problem is, NG, of course, not a big issue, but with regard to PEG, which is a small procedure, now we have another principle with regard to palliative patients. When they are very close to the death, the last few weeks and last few months, whether we should do any procedures. And it's also known that if your lung function, the forced vital capacity is less than 1 liter, where we think patient is terminal, by going for a PEG tube at that stage, it's not going to do good for the patient. So it's not indicated. The moment you decide maybe this patient needs a PEG, his dysphagia has gone to that extent, you must check the lung function. If your forced vital capacity is less than 1000, this patient is not going to tolerate PEG tube. If you go for a PEG tube, most likely they will die within the next day or two with aspiration. They cannot tolerate. During the procedure, you aspirate a little. You need a little bit of respiratory function to overcome that. So it's not going to work. So last few months, we are not going to do this. So in other words, whenever a PEG is necessary for advanced neurological problem, progressive neurological problem, whether it's motor neuron disease, whether it's something else, if your respiratory function also has been affected, we do not go for PEG if your vital capacity is less than 1000. The rule of thumb, remember, whenever you decide to go for a PEG, check the forced vital capacity, check the respiratory function clinically. If it's clinically too advanced, you don't need vital capacity assessment, you can decide it. But if you are doubtful, you need to go for a forced vital capacity. Remembering the fact that forced vital capacity, the value depends on the patient effort also. So you need to have a good assessment about the patient's respiratory function. Now there's a question. My patient is having a vital capacity of 1200. My motor neuron disease patient has a vital capacity of 1200. And he's not having dysphagia, he's having mild dysphagia, but it's likely that within the next few months, patient will go to the level that you need PEG tube. But by the time the patient PEG tube is indicated, most likely my patient's vital capacity may drop below 1000, in which case I will not be able to go for a PEG. I'll repeat the case scenario again if you did not follow me. My patient's vital capacity right now is 1200, motor neuron disease patient. His dysphagia is currently mild. He's tolerating oral feeds, but I'm thinking that he will progress, his dysphagia will progress to the stage needing PEG feeding very soon. But by the time his PEG is indicated, I'm wondering whether my vital capacity, my patient's vital capacity will drop below 1000, in which case I will not be able to go for a peg? Is it possible to go for a peg right now and keep it for future use? Answer is yes. You can go for a peg if you are on the verge of crossing the vital capacity criteria and keep it ready for future use. That's been happening. So something to be aware of. Few patients have mild dysphagia, but significant progression is taking place. You may go for a peg early to be used in future. Okay. If you have questions, you can disturb me and ask, or at the end of the lectures, you can ask. Sorry, is there a question? Okay. All of you have seen how the peg tube is placed, and once a peg is put, patient is little comfortable because no one sees the tube. When the tube is in the nose, everyone sees. Patient look like a sick fellow. Okay, the pain management, of course, you will hear more from others. Spasticity, there are various ways of overcoming spasticity. There are drug treatment, therapies, and drooling. There are various drugs. Atropine is being used. Even atropine while under the tongue also can be used. And then hyoscine and immobility is a common problem with neurological disorders. Because there's another topic, I'll quickly go through this. Emotional lability, also there are drug treatments available. Communication also gets affected. You usually communicate with your verbal communication, but when the verbal communication is gradually getting lost, then you use your fingers and hands, you write, you type, or maybe you can point to picture charts, indicate what you want to say. And then your hands also getting weaker, then you don't have hands also, in which case there are newer gadgets where your eye movement can be tracked, and with the eyes you can move the cursor on a computer and then type what you want if your eye movements are intact. Usually eye movements are intact till the last stage of this illness. So these are some of the things. Psychological aspects, social aspects you need to look at. Of course, spiritual aspect, you will hear them in different lectures. Breaking news. Let's deviate from this quickly to I have another topic to cover, status epilepticus. Do you have any questions with regard to the current presentation? I can spend a minute if you have questions, or else I'll switch to the next one. Okay, in the absence of questions, let's move to the next topic. Status epilepticus is seen in palliative patients, not only neuropalliative patients, even in other palliative patients. Sometimes they have secondaries in the brain, they cause status epilepticus, or many other reasons they can have status epilepticus. Let's discuss status epilepticus as a entity, and then we'll discuss how it's neuropalliative patient, how it differ. In fact, this presentation is too long. I'll try to skip some of the slides while I'm going through. Everyone knows the difference between seizure and epilepsy. Seizure is just one occurrence. Epilepsy is tendency to have many. So when you diagnose epilepsy, it indicates that you're likely to have them in the future. And loss of consciousness episodically can happen from many reasons. Epilepsy, syncope, and many other conditions also there. Let's skip this. All of you are aware. Seizure and syncope, how to differentiate. Seizures are usually, there's no warning immediately, you just drop and then have a seizure. Syncope, there's a warning symptom. Patient can feel. This is a common way things happen. Syncope cannot happen in the lying down position, but seizures can happen during lying down position. Tongue biting is a common in seizures, and urinary incontinence common in seizures, fecal incontinence common in seizures, and patients immediately comes back to normalcy in both of them. But in seizures, sometimes you see patient remain drowsy or sleepy for a period of time before they come back to normalcy. Syncope, they come back very quickly. Another differentiation necessary if you have a seizure is whether they are psychogenic epileptic, non-epileptic attacks. Usually occurs when people are around and never occur during sleep. Usually there is no tongue bites or urinary incontinence. Eyes are closed usually. And if you try to open the eyes, there is resistance in non-epileptic psychogenic ones. Suggestibility. You can suggest to the patient, maybe after taking this tablet, you will get a fit. And sometimes they throw the fit. Injury is uncommon. Hyperventilate and vocalization is there. Pelvic thrusting, head movements, body rolling to side, no postictal or pre-ictal phenomena, not stereotyped. Stereotypy means every attack happens in the same sequence. Psychogenic ones is A stereotyped. Interictal video and EEG. So psychogenic attacks, you do an EEG during the episode, you see that's normal. So diagnosis of epilepsy is clinical, supported by EEG or many other things. Nowadays, we ask a patient to produce home videos when you don't see them. And EEG is useful, but it's not a diagnostic test. It's just an extension to the clinical evaluation. Can be normal in epileptics. You can have abnormal discharges, epileptiform discharges in non-epileptics. So it's just an extension to the evaluation. It's not a diagnostic test. There was an old classification before 2017. This was the classification we learned, but currently we have a newer classification. Earlier it was partial, primary, generalized, and so on. So the newer classification is this. I don't have time to go through this, but certain earlier terms have been dropped and the new terms have replaced them. And then they discuss about epilepsy syndromes. There are various, epilepsy is not a diagnosis, but when you say epilepsy syndrome, it's a diagnosis. So it's about how partial seizures occur, how primary generalized seizures occur, and then how partial with secondary generalization occurs. And that's an EEG of a generalized seizure. I'm trying to come to status epilepticus faster because these are initial slides. So causes of epilepsy, there are many, can be generalized. So genetic epilepsies like JME, juvenile myoclonic epilepsy, can be developmental and hippocampal sclerosis, brain trauma, the list goes on. And we need to understand this phenomenon, which is seizure threshold. Everyone going above the level will throw a fit. And the seizure threshold can go up and down due to many reasons. Fever reduces the threshold, increasing the chance for seizure. And then anti-epileptic drugs will increase the seizure threshold. Every one of us has a seizure threshold. Given adequate amount of stimulus, can throw a fit. And there are precipitants. These are the ones who will reduce the seizure threshold: sleep deprivation, fever, anti-epileptics withdrawal, alcohol, and so on. Let's discuss about status epilepticus, which is defined as continuous seizure activity. Usually, most common thing is seizures, they just occur and then they settles within a minute, maximum 5 minutes. Why the seizure happens all of a sudden and why seizure stops, most of them, how that happens is a question. Seizure genesis at a molecular level and how does a seizure stops in normal fellows within 5 minutes is, I don't have time to discuss that. But in most patients, breakthrough seizures, just stay a maximum of 5 minutes. And when the stopping mechanism is not effective, they go into status epilepticus. They can have 2 or 3 seizures in succession without regaining consciousness, or maybe the seizure can continue beyond 5 minutes. So if you want to diagnose status epilepticus, make sure that seizure is continuing beyond 5 minutes, or there are frequent many seizures happening in between. There is no regaining of restoration of the conscious level. It's important that you diagnose status epilepticus at the beginning, because how you manage your management steps works well at the beginning of the status epilepticus. If you are very slow, you wait and wait, you find it more difficult to manage them. So hit hard from the beginning is the way to go for managing status epilepticus. The best drug that you're going to use is benzodiazepine. Let's discuss in the subsequent slides. So status epilepticus can be convulsive or non-convulsive. Status epilepticus is a medical emergency. You have to act fast. So we have discussed the textbook definition is status epilepticus to be there for more than 30 minutes for you to diagnose, but that is not the practical definition. Practical definition is when a seizure is beyond 5 minutes, you need to consider that this patient is in status. Little overdiagnosis may be not a problem, but underdiagnosis can give to trouble. So that's the practical definition or operational definition for us. More than 5 minutes continuing, or more than 2 discrete seizures in between you have lost consciousness. These are some of the terms. Do you know status epilepticus? Someone who never had a neurological problem suddenly presents with status epilepticus. It's rare, but sometimes this happens. Okay, now with regard to etiology, there are many reasons why you present with status epilepticus. I'm running through them. Some of them are not very important. So that's the seizure starting mechanism and the stopping mechanism. Because of the time constraint, I have to run through faster. There's some of the effects. If you do not treat adequately, you can have cortical laminar necrosis in some of them. So there can be seizure mimics in status also. So it's important that you properly diagnose status epilepticus. And let's go to the ideal agent that you're looking for managing status epilepticus is 100% bioavailable, quick onset of action with a prolonged duration of action, stops seizure in 100% of them, with a broad spectrum of activity for every kind of status epilepticus, which will be free of side effects, which can be delivered in IV, IM, buccal, PR, nasal, whatever the routes. These are the ideal agent which is not existing. Hence, rapid assessment is necessary. Like in any other medical emergency, you need to diagnose them properly. So ABC, airway, breathing and circulation, and oxygenation needs to be looked after. So you need IV lines for drugs and bloods and cardiac monitoring. Sometimes you go into status epilepticus because of hypoglycemia. Diabetic, they can present with status epilepticus as a phenomenon for hypoglycemia, where you need to give dextrose, but you have to make sure dextrose should be combined with thiamine. In patients who are thiamine deficient, if you just give dextrose, you can have trouble. Ideally, the teaching is to give thiamine first and then dextrose, but it's okay to give both in the same go, but not the other way. So first line therapy will be benzodiazepines. Second line is IV anti-epileptics. The third line are anesthetic agents. And super refractory cases, you will consider other forms of treatment. Benzodiazepine in the early phase gives the best seizure freeness. So we have many to choose from. I will not have time to go through. You can find these doses and everything from what we normally use is diazepam in our country. Lorazepam is not widely available. I'm not sure what pediatric wards maybe is available, but it's very costly. From the cost point of view, diazepam is okay for us, and midazolam is available for us. But normally we give diazepam initially, and then midazolam comes to the last stage where you give midazolam infusion. It's a short-acting one. And the second stage, the practice was to give phenytoin IV, which was available. Still, it's available. Though oral phenytoin is going out of favor because of long-term side effects for epilepsy, IV phenytoin still is there for management of status epilepticus. Only thing, you have to correctly calculate the dose and not to exceed the rate of infusion. You need cardiac monitoring, blood pressure monitoring, and so on. Now we have got IV valproate, IV levetiracetam. Not sure about in the hospitals, but private sector they are available, having equal efficacy, or sometimes they say superiority also. So third stage is by the anesthetist in the ICU. You think of anesthetic agents, propofol, thiopentone, and midazolam infusion, and so on. Okay. So with regard to palliative patients, let's stop here and discuss about palliative patients getting status epilepticus. Sometimes they are at home, they are terminal. We are not thinking of managing them in the ICUs, and we are trying to prevent injections also among them. So we have little restrictions how we can control. So one of the things is, of course, if we can admit, if you think patients in the early palliative period in the trajectory where sometimes you do most of the things, patient may end up in the ICU and all the full management may go. But in the terminal stage, the large stage, you may prevent doing so many things. Maybe midazolam infusion, or maybe rectal use of benzodiazepines, diazepam, and so on. If you have a PEG, you may use that to give anti-epileptic. So you adjust your management to suit the patient, depending on the patient stages. Control of epilepsy, is it required in the terminal stage? Status epilepticus? Maybe, because patients should look dignified throughout the palliative period. These palliative patients, sometimes they are, VIPs. They are very, serve the country a lot. Maybe a school principal, maybe a doctor, maybe a nurse. And at the last stage of life, we should keep them dignified in the wards when they are managing, or even at home. They should look very dignified on the bed. So certain, we look at that aspect also. So the amount of things we do are limited, but you will be creative and adjusting your management to suit that situation. Okay, so I'll stop there. And if you have any questions, I'm ready to answer.